welcome to the deep dive. Right, you're here probably knee-deep in MSRA prep, and beta-thalassemia trait is definitely on that list.
Oh, absolutely. It crops up a lot.
So we've taken your MSRA revision notes, boiled them down, basically trying to give you the high-yield stuff you really need for the exam.
Yep. Think of this as your focused briefing on this specific condition.
Exactly. Our mission today is to pull out all that crucial knowledge on beta-thalassemia trait, make sure it sticks, and, maybe give you a few memory aids, too.
Let's do it. And we're focusing just on the trait today, remember? The carrier state. It's genetic, less beta-globin production,
Yeah.
but just one faulty gene involved.
Milder form, but essential MSRA knowledge.
Totally essential.
Okay, so let's get crystal clear. Beta-thalassemia trait. What exactly is it? Define it for us.
Right. So at its heart, it's a genetic condition. The body basically makes less of the beta-globin chains.
Which are needed for hemoglobin.
Precisely. Hemoglobin, carrying oxygen in your red blood cells. And because it's the trait, it means you've only inherited one dodgy beta-globin gene, usually from one parent.
Okay.
It's part of a bigger group, autosomal blood disorders, all linked to mutations on that beta-globin gene. This leads to less beta-globin overall, and that causes microcytic anemia, those smaller red cells.
Right, the microcytic picture.
Yeah. And it's worth remembering, hemoglobin isn't just one type. You've got HbA, HbF, HbA2, and thalassemias mess with the production of the chains, either alpha or beta, that build these hemoglobin.
And this is the beta side we're focused on. You mentioned different types of beta-thalassemia.
Yeah, so you've got thalassemia split into alpha and beta branches. Within beta, there's like a spectrum of severity. You've got normal, then the trait, that's our focus, and intermediate, and beta-thalassemia major, which is the really severe one.
Major needs transfusions and stuff.
Often, yes, significant anemia. But the trait, carrying just that one altered gene, is much milder.
Got it. Okay, so what causes it? What's the actual etiology of the trait?
It boils down to mutations in a specific gene called the HBB gene. This gene holds the instructions for making beta-globin.
Okay.
These mutations mean you either make less beta-globin or the beta-globin you do make doesn't function quite right. But the key for the trait is inheriting only one copy of this mutated gene.
From one parent?
From one parent, yeah. It's an autosomal recessive pattern overall, so usually you'd need two copies, one from each parent, to get the more severe forms like major.
So inheriting just the one makes you a carrier, but generally you're okay health-wise.
That's usually the case. There are actually loads of different HBB mutations, and sometimes the specific mutation can slightly change things, but generally having one working gene is enough to avoid serious illness.
Right, so who's most likely to have this trait? What are the risk factors we need to have on our radar?
Okay, number one is family history. If beta-thalassemia runs in the family, or someone's a known carrier, the risk is obviously higher.
Makes sense.
Second, and this is really important clinically, is ethnicity. It's much more common in people whose families originally come from the Mediterranean area, the Middle East, or Southeast Asia.
Definitely something to ask about.
Absolutely. And thirdly, maybe less common in the UK generally, but still relevant, is consanguineous marriages between relatives. In areas where that's more common and the gene is prevalent, the risk goes up because you're more likely to inherit two copies.
Okay, so family history, ethnicity. Crucial clues.
Yeah.
Now let's get down to the biology. What's actually happening inside the body? The pathophysiology.
So you've got reduced beta-globin, right? But your body's still making alpha-globin chains normally. This creates an imbalance.
Too much alpha relative to beta.
Exactly. And that imbalance is the core problem. It causes something called ineffective erythropoiesis.
Ineffective red blood cell production.
Yeah, basically. The bone marrow tries its best to make red blood cells, but because they're lacking the right amount of beta-globin, they end up being faulty. And many of these faulty cells get destroyed before they even leave the marrow or soon after. The end result is a mild anemia because you just don't have enough fully functional hemoglobin carrying oxygen.
And the severity varies a bit.
It can, depending on the exact mutation and other factors, but for the trait, it's typically mild.
Okay, mild anemia, which sounds like it could be confused with other things. What are the main conditions we need to differentiate it from? The differential diagnoses.
This is super important for the MSRA. Top of the list definitely is iron deficiency anemia.
Because both cause microcytic anemia.
Exactly. Both give you small red cells. But here's the critical difference. In beta-thalassemia trait, your iron levels, serum, iron, ferritin, are usually normal or even high. In iron deficiency, they're low.
Ah, okay, that's a key distinction.
Massive distinction. Remember, high iron in thalassemia trait. Another big one is alpha thalassemia trait. It's also genetic, also causes microcytic cells.
How do you tell them apart?
Hemoglobin electrophoresis, that's the test that'll usually show the difference, particularly the HbA2 level we'll talk about later.
Right. What else?
Well, you should also think about other hemoglobinopathies like sickle cell trait or HBE trait, though they often have other features. And don't forget the broader category of microcytic anemias, things like sideroblastic anemia, maybe anemia of chronic disease, though that's often normocytic initially.
Any really serious things to rule out?
In rare atypical cases, especially if other blood counts are off, you might need to consider acute leukemia, maybe needing a bone marrow check. And in newborns, rhesus incompatibility can cause issues, but electrophoresis helps there too. Oh, and Diamond-Blackfan syndrome causes anemia, but it's usually macrocytic big cells, so the opposite picture.
Okay, quite a list to keep in mind, but that iron level difference is key. How common is this trait? Let's talk epidemiology, UK, and globally.
Okay, so in the UK, we don't have exact prevalence figures across the board, but we know it's much more common in people with those ancestral links we mentioned, Mediterranean, Middle Eastern, Southeast Asian.
Reflecting the global pattern.
Exactly. So the overall UK prevalence might seem lower, but it's definitely present in those communities and families with a known history. Globally, though, it's actually really common. Estimates suggest around 1.5% of the world's population are carriers.
Wow, that's a lot of people.
It is. That's something like 80 to 90 million people carrying the beta-thalassemia gene. It's very prevalent around the Mediterranean, Middle East, parts of Asia, southern China.
And with migration.
It's spread everywhere, so you can't just rely on someone's current location. You need to consider their background. You'll see it in diverse patient populations right here in the UK.
Good point. So clinically, what might make you suspect beta-thalassemia trait? What are the features?
Okay, the absolute key thing to remember here is that most people, the vast majority with the trait, are completely asymptomatic.
Feel totally fine.
Feel totally fine. Often don't even know they have it unless it's picked up on a routine blood test or screening. Some might have a very mild microcytic anemia, maybe leading to slight fatigue, but often not even that. Interestingly, while the main issue isn't iron, some people with the trait can still become iron deficient for other reasons, and if that happens, it can make any mild anemia a bit worse.
So you can have both.
You can, yeah. But the underlying trait means their baseline red cells are small. The hallmark finding on the bloods is that mild hypochromic microcytic pictures small, pale red cells. And the really crucial diagnostic clue, which we'll get to with tests, is a raised level of HbA2.
HbA2. Got it.
Yeah.
And this is very different from beta-thalassemia major.
Oh, completely different picture. Major causes severe anemia, serious fatigue, breathlessness, often an enlarged liver and spleen, needs major treatment. Intermediate is, well, intermediate, somewhere between trait and major.
And screening helps pick up the trait.
Yeah, antenatal screening programs and newborn blood spot screening, especially in areas or populations with higher prevalence, are really important for identifying carriers.
Okay, so often no symptoms, but the blood tests are key.
Yeah.
What specific investigations nail the diagnosis?
It really comes down to the bloods. First off, the complete blood count, the CBC. You're looking for that low MCV, the microcytosis, and often slightly low hemoglobin, maybe a high red cell count sometimes too.
And the iron studies.
Crucial differentiator. Check the serum iron, ferritin, transferrin saturation. In uncomplicated beta-thalassemia trait, these are typically normal or even elevated. That points you away from iron deficiency.
And the definitive test.
The gold standard is hemoglobin electrophoresis, or increasingly HPLC is used. This separates out the different hemoglobin types. In beta-thalassemia trait, you characteristically see an elevated HbA2 level, usually over 3.5%. That's the classic finding.
Raised HbA2. That's the one to remember.
That's the big one. DNA testing is also possible, usually in specialist labs. That's more for confirming specific mutations, maybe for genetic counseling for couples, prenatal diagnosis, or PGD.
And things like scans or bone marrow tests.
Generally not needed for diagnosing the trait itself. They come into play more for the severe forms or if you're trying to rule out other complex diagnoses. For straightforward trait, CBC, iron studies, and electrophoresis are usually enough.
Okay, clear. So diagnosis made usually CBC, iron normal high, HbA2 high. What's the management plan for someone with the trait?
Well, the really reassuring thing, and this is important to tell patients, is that for beta thalassemia trait itself, usually no specific medical treatment is needed.
So no medicines or anything.
Generally, no. Good general health advice applies balanced diet. Some might suggest folic acid supplements, as folate is needed for red cell production, which might be slightly increased, but even that isn't always standard.
What about iron?
Ah, critical point. Avoid routine iron supplements unless you've proven they are also iron deficient. Remember, their iron levels are often normal or high anyway. Giving extra iron unnecessarily could actually cause problems like iron overload down the line, although that's more of a risk with repeated transfusions in severe thalassemia.
So check iron levels before ever giving iron.
Absolutely. The mainstays of management are really awareness, monitoring hemoglobin levels occasionally, and crucially, genetic counseling.
Why is counseling so important?
Because if someone with the trait has children with a partner who is also a carrier, either a beta-thalassemia trait or sometimes another related gene, there's a 1 in 4 risk with each pregnancy of having a child with beta-thalassemia major, the severe form.
Right, the autosomal recessive pattern.
Exactly. So understanding that risk, partner testing, and options for prenatal diagnosis are key discussions. We should briefly mention that treatments for severe beta-thalassemia exist: transfusions, iron chelation, stem cell transplant. But again, these are not for the trait.
Okay, so management is mainly awareness, counseling, avoiding unnecessary iron. What about the long-term outlook, the prognosis?
Generally, the prognosis is excellent. People with beta-thalassemia trait live normal, healthy lives. Life expectancy isn't affected.
That's really reassuring.
It is. There aren't really any significant long-term health problems directly caused by the trait itself. Long-term management really just involves that awareness, occasional monitoring, and the genetic counseling aspect we discussed, especially around family planning.
A huge contrast to the severe forms then.
Absolutely. For beta-thalassemia major, prognosis depends heavily on treatment adherence, managing complications like iron overload. It's a much more complex picture. But for the trait, or minor, as it's sometimes called, it's compatible with a completely normal lifespan.
Great. So if the prognosis is good, are there any complications associated specifically with the trait itself?
Directly from the trait, generally no medical complications to worry about. That's a really key message for you for the MSRA.
So the main complication is the genetic risk.
Precisely. The primary issue or risk associated with being a carrier is the possibility of passing it on and potentially having a child with a severe form if the other parent is also a carrier. That's why carrier screening in relevant situations and genetic counseling are so vital. It's good to know the complications of severe beta thalassemia, like iron overload from transfusions, infections, maybe spleen problems, bone changes. But you need to be clear in your mind, these are not features of the trait.
So for the trait, it's all about prevention through counseling and testing.
That's the main focus, yes. Identifying carriers allows for informed reproductive choices.
Okay, this has been super helpful, really clear. Now, to lock this in for the exam, any killer memory tips or maybe an example question?
Yeah, let's try. For diagnosis, remember the key features. Microcytic anemia with high A2. Think MAHA2.
The MAHA2. Microcytic anemia, high A2. Nice.
And to differentiate from the most common confusion, remember, high iron and thalassemia trait. That reminds you ferritin and iron are usually normal or up, unlike iron deficiency.
High iron and thalassemia trait. Got it.
Okay, MSRA style question time. Picture this. A 25-year-old female of Mediterranean descent presents. She's feeling a bit tired, nothing major. Her full blood count shows hemoglobin 110 GL, MCV is low at 65 FL. Her serum ferritin comes back high at 450 mL/GL. What's the most likely diagnosis?
Okay, so Mediterranean background, mild symptoms, microcytic anemia, low MCV, but high ferritin. That rules out iron deficiency. Got to be beta-thalassemia trait.
Exactly. The ethnicity, the microcytosis, and the high ferritin all point strongly towards beta-thalassemia trait. So general memory jog. You see microcytosis, check the ethnicity, check the iron ferritin. If iron is normal or high, think globin problem, not iron problem. Think thalassemia trait.
Brilliant. Okay, let's quickly recap the absolute essentials for beta-thalassemia trait.
Okay. It's a mild genetic condition, usually asymptomatic, causes mild microcytic hypochromic anemia. The key diagnostic marker is raised HbA2 on electrophoresis. Iron studies are typically normal or high.
And management.
Generally, no treatment needed. Avoid unnecessary iron. Main thing is genetic counseling regarding risks to offspring if the partner is also a carrier.
And crucially for the MSRA, know how it differs from iron deficiency and from the severe forms of thalassemia.
Nail it. Understand the trait versus matter distinction.
Perfect. So, Just before we finish, here's something to mull over.
The provocative thought.
Yeah. Given how many millions of people worldwide are carriers for beta-thalassemia, how do you think population screening programs might, or maybe should, evolve in the future to better identify couples at risk?
That's a big question. Balancing benefits, costs, ethics.
Hmm.
Definitely food for thought.
Indeed. Okay, for all of you listening and revising, if you want more comprehensive MSRA resources, do check out pastthemsra.com.
And there are also loads of great free materials available over at freemissstory.com. Definitely worth a look.
Thanks for joining us for this deep dive on beta-thalassemia trait. Good luck with the revision.